Today, a review period extended in gastrointestinal stromal tumor, disappointing findings in lung cancer, a European application withdrawn in lung cancer, European positive opinions in myeloma and of a biosimilar, and ASCO announces its cancer advance of the year. Welcome to Enclave News Network. I'm Gina Columbus. The FDA has extended the Prescription Drug User Fee Act deadline for a new drug application for avapritinib as a treatment for adult patients with fourth-line gastrointestinal stromal tumor. The deadline, which was initially February 14, 2020, has been extended by 3 months to May 14, 2020. Previously, the FDA requested top-line data from the company's ongoing Phase 3 Voyager trial, which is evaluating avapritinib and regorafenib in third- or fourth-line GIST. The data are slated to inform the pending action on the application for the fourth-line setting. Additionally, Blueprint Medicines, the developer of avapritinib, slated that it plans to provide the top-line data to the FDA in the second quarter of 2020, so that the agency will be able to decide on the application by the new deadline. The company also announced that the National Comprehensive Cancer Network updated its clinical practice guidelines in oncology for soft tissue sarcoma to include avapritinib as a recommended Category 2A treatment for patients with unresectable or metastatic GIST with a PGD-FRA exon 18 mutation, which includes PDG-PRA-D842V mutations, and fourth-line GIST. In January 2020, the FDA approved avapritinib for the treatment of adult patients with unresectable or metastatic GIST harboring a PDG-FRA exon 18 mutation, including PDG-FRA-D842V mutations. In non-small cell lung cancer, the addition of dinutuximab injection to irinotecan did not improve overall survival versus irinotecan or topotecan alone in patients with relapsed refractory small cell lung cancer, missing the primary endpoint of the Phase 2-3 DISTINCT trial. Dinutuximab is a GD2 binding monoclonal antibody approved for use in combination with granulocyte macrophage colony-stimulating factor, interleukin-2, and 13-cis retinoic acid as a treatment for pediatric patients with high-risk neuroblastoma who achieve a partial response or greater to prior induction treatment. The top-line data also showed that the safety profile of the combination was consistent with prior studies and the current label for dinutuximab. Full results will be presented at an upcoming medical meeting and will also be included in peer-reviewed publications. A label expansion for dinutuximab in combination with irinotecan and temozolomide for the treatment of pediatric patients with relapsed refractory neuroblastoma is also being pursued. Bristol Myers Squibb has withdrawn its application in the European Union for the frontline combination of nivolumab and ipilimumab as a treatment for patients with advanced non-small cell lung cancer. The application was originally filed in 2018 as a first-line treatment for patients with NSCLC who have tumor mutational burden higher than 10 mutations per megabase and was based on final progression-free survival findings from the Phase 3 CheckMate 227 trial. The application was also later amended to include overall survival data from Part 1A of CheckMate 227, which compared nivolumab plus ipilimumab with chemotherapy for patients whose tumors express PD-L1 greater than 1%. While the European Medicines Agency's Committee for Medicinal Products for Human Use recognized the integrity of the patient-level data, the committee determined that a full assessment of the application was not possible following the multiple protocol changes the company had made. There are no plans to refile the application in the European Union. The European Medicines Agency's Committee for Medicinal Products for Human Use has adopted a positive opinion for a marketing authorization application for the rituximab biosimilar PF-052-80586 for the treatment of patients with non-Hodgkin lymphoma, chronic lymphocytic leukemia, rheumatoid arthritis, granulomatosis with polyangiitis, and microscopic polyangiitis, and pemphigus vulgaris. The submission is supported by a comprehensive data package demonstrating biosimilarity with PF-052-80586 to reference rituximab, including results from the Reflections B3281006 study. The trial evaluated the efficacy, safety, and immunogenicity, pharmacokinetics, and pharmacodynamics of PF-052-80586. Results showed that there were no clinically meaningful differences in safety or efficacy between the biosimilar and standard rituximab in patients with CD20-positive, low tumor burden follicular lymphoma. The European Commission is expected to make a decision on the approval in the first half of 2020. In multiple myeloma, the European Medicines Agency has validated a marketing authorization application for belantamab mafodotin for the treatment of patients with relapsed refractory disease whose prior therapy included an immunomodulatory agent, a proteasome inhibitor, and a CD38-directed monoclonal antibody. The antibody-drug conjugate was accepted for accelerated assessment by the EMA's Committee for Medicinal Products for Human Use. The application is based on data from the pivotal DREAM2 study in which belantamab mafodotin demonstrated an overall response rate of 31% with the 2.5 milligram per kilogram dose of belantamab mafodotin in this patient population. In patients who received belantamab mafodotin at 3.4 milligrams per kilogram, the ORR was 34%. The safety data were consistent with previously reported data on belantamab mafodotin. Following significant progress made in the development of novel systemic therapies for patients with cancer, the role of surgery and oncology continues to evolve. For this reason, ASCO has selected the refinement of surgical treatment of cancer as its advance of the year, as part of Clinical Cancer Advances 2020, ASCO's annual report on progress against cancer. ASCO stated that substantial progress has been made in prior years in the understanding and development of systemic therapies in cancer care. However, the impact of these advancements on surgical care has only come to light recently. Examples of refined surgical techniques include less invasive surgery in melanoma due to neoadjuvant immune-based combination therapies, TKIs as an alternative to cytoreductive nephrectomy in kidney cancer, and higher resection rates from neoadjuvant treatment in pancreatic cancer. ASCO's annual update on advances made with oncology treatments spotlights pivotal clinical research milestones and policy developments that have been made over the past year. This week, we sat down with Dr. Ghassan Abu Alfa of Memorial Sloan Kettering Cancer Center to discuss the results from the Phase 3 I Am Brave 150 trial.
We all kind of were very highly anticipating and same time looking forward, and I would say that we're very happy to see the results of the I Am Brave 150 study that, if you recall, looked at patients with advanced hepatocellular carcinoma and randomized patients to atezolizumab as an anti-PD-L1 plus bevacizumab as an anti-angiogenic versus sorafenib as a standard of care. This study was available and was made available for patients who had advanced liver cancer, either locally advanced, not amenable to local therapy, or metastatic disease, good liver performance, Child-Pugh scoring, understandably no prior active bleeding by varices. Actually, if I recall, it required 6 months of previously treated, no active action on any varix, or of course, no event within the month that happened before going on the study. So they were very, very kind of cautious to make sure that any potential anti-angiogenic effect of bevacizumab will not ultimately cause any potential variceal bleed. So this was a very important point and very key point of the study. With this said, when the patients were randomized, ultimately it was with the aim of a primary point being overall survival, but also another primary point was progression-free survival, which made sense, especially with the advent of so many therapies. It made sense to look from different perspective or use a different set of eyes to look at what the study might do. What I like the most about the I Am Brave is that if you look at the demographics of it, it's really the bread and butter of what we see in clinic. I would say that it is very, in grosso modo, similar to what we have seen, for example, with the SHARP trial, with the Celestial study later on, and everything in between. And if anything, patients had the median age for liver cancer, like in the mid-60s or about. Of course, understandably more men than women. The distribution among the ethnicities was rather very global. Etiologies or risk factors, again, was pretty apparent for all of them. Some people might say, oh, maybe a little bit more Asia heavy. I wouldn't say necessarily so, because remember, we see Hep B in other parts of the world as well, and we have Asian descent patients in many parts of the world. Um, there was a kind of distribution of about like more than 80% patient with BCLC-C, i.e. metastatic disease, about like close to 20% or less BCLC-B. Again, same distribution we see in other cancer, in other studies that we have seen before. This study, if anything, completed its accrual. It was rather robust, quite impressive, like how fast they were able to accrue the study. And I would say that what's impressive is that in this 2-to-1 randomization, the outcome of the atezolizumab plus bevacizumab was far better than it was for sorafenib. If anything, the overall survival, median overall survival was not yet available for the atezolizumab plus bevacizumab study, which is nice. And at the same time, for the sorafenib, it was about 13 plus months, which is similar to what we have seen in different studies, like, for example, the lenvatinib versus sorafenib study. The progression-free survival, and by the way, the overall survival also was, statistically significant. I think the hazard ratio, if I'm not mistaken, was like 0.58 or 59, and the p-value was like as many zeros as you want, 6 or 1. The progression-free survival was also positive. Maybe you can say I would have anticipated a little bit more than that, but nonetheless, it's about like 6 months for the atezo-bev versus about 4 months for the sorafenib. Again, clinically and statistically significant, with the hazard ratio of 0.58 or 59, and the p-value of 0.0006, I recall. So clearly, the study is positive. There's no if and but about it. The secondary endpoints were multi. And if anything, I'm sure we're going to hear more and more about that study as it comes out with more of the qualitative components, what have we. But it's nice to see that the responses were really robust, and we have seen what was defined as CR, PR, things that we never heard of in HCC. So these are definitely very nice to hear. And as far as side effects, what we all thought historically that bevacizumab in its prior experience in liver cancer might lead to potential increase in potential bleed, and this was this first study that was reported in JCO on bevacizumab in liver cancer. Surprisingly, not much, and if anything, maybe good for the investigators and the sponsor. They really were very careful about putting the true eligibility criteria, i.e. patients without an active bleed, as we said, no prior active bleed for a long time, definitely paid back because definitely they saw, if at all, limited or barely countable amount of bleeding toxicity, especially varices. So I would say, all in all, the drug was very well tolerated. Of course, on that point, it will be important to be recognizant that as this therapy, and I hope and I do expect that it's going to be available for all of us in use, to make sure that patients are screened ahead of time, same way it was on the study, with the scope being evaluated, to ensure that they are, of course, appropriately eligible, and they will be safe to give the drugs. And this is a message that I sent to all colleagues of ours, no matter what your practice is. If you are to think of atezolizumab plus bevacizumab therapy, make sure that you send your patients for a endoscopy, at least for screening purposes. Of course, I knew you were going to ask me that, and like, am I using atezolizumab, bevacizumab? Actually, I'll ask the question to all of us: are we using it? And by all means, I am, because if anything, the drugs are now available, and if anything, with the data, you can at least attempt with whatever support the patient has for getting their medical care to see if they will approve it, and hope that they will, because at the end of the day, we cannot deny such good therapy for our patients. Even though I do recognize that we have to wait for the completion of the data, even though if the study already is in 19th months and still we did not cross the median for the atezolizumab, bevacizumab, what's going to be? Like, even if everything goes bad today, it's still worth about 19 months. But of course, it's going to be probably expecting a little bit longer. So by all means, this is a rather positive study. It was very nice and exciting and invigorating to see it happening and presented at ESMO Asia this year.
That's all for today. Thank you for watching Enclave News Network. I'm Gina Columbus.